Good morning, class. This is Principles of Health Science. This is the actual afternoon class, even though I'm videoing this in the morning related to virtual learning. This is the part 2 of Principles of Health Science, Healthcare Systems. We're going to start, I'm going to pick up where I left off yesterday. I'm going to do a short video, short lecture, probably about 15, 20 minutes at the most, and see how much of this we can cover together. I see there we have had students come and get books. That's awesome if you can come and get your book. If you cannot, that's okay. On Monday you'll have it. Again, let me reiterate that you'll have from Monday until Friday to complete your assignment of those review questions. Now, those review questions that I put up on Canvas is actually in the back of this chapter, questions 1 through 8. And those questions are worth 100 points. If you have any questions, you can email me, send me a message, call me here at school. That would be great. So let's pick up where we left off, and we're going to talk about healthcare facilities. Private healthcare facilities, there's government healthcare facilities. We're going to mention a few. Again, I'm not going to read to you word for word or verbatim. It's going to be just kind of an overview. So what are some facilities that we have? We have hospitals. We have long-term care facilities, otherwise known as nursing homes. We've got independent or assisted living facilities. We have medical offices. We have dental offices. We have clinics. We have optical centers. We have emergency care services. We have urgent treatment centers, laboratories, home health care, hospice, mental health care, genetic counseling, rehabilitation. We have health maintenance organizations. They help to maintain people's health. It takes over and kind of guides care. We have industrial health care centers, and we have school health services. So we have plenty of facilities to take care of people in different situations, depending on where they're at and how they present with their illness or injury, or even wellness. Wellness. If we focused on wellness, we might not get sick as much. Very, very good possibility. So we actually, if you could break it down as far as hospitals, you have hospitals that actually specialize in certain areas. Like this hospital is known as the best heart hospital. This hospital is known as the best stroke center. This hospital deals just with burns. So there's different types of hospitals. Long-term care facilities, there used to be and there still is to a certain point, levels of care, different levels of care in nursing facilities, from personal care to intermediate care to skilled care to a subacute care to rehabilitation inside healthcare or long-term care facilities. Just let me say here that in long-term care, and that's kind of what, with Medicaid Nurse Aid, this program, let me tell you a little bit about the program. In the all the way up to the early to mid 80s, there was not a standard of care for training nursing assistants. The instruction or the education you received as a nursing assistant was on the job. With being on the job, it depends on how well or how good your preceptor was, how good that hospital was, how good that organization was at training you. Some of them did an excellent job, others not so well. And they were looking for a standard for care of the elderly, the sick, the infirm. So in 1987, President Ronald Reagan signed into law the Omnibus Reconciliation Act of 87. So what that did was set a set of standards for nursing assistants that they had to receive, and it took 3 years to get everything lined out to where it began. It was in 1990 that this program took off. It was being signed into law in 87. There was some time to get it running, get the feet on the ground. Figure out how since that law was in place, how's it going to be put? How's the regulations going to be written? So that's where it all started, 1987. I was in one of the first classes to receive my certification or certificate to be able to teach Medicaid Nurse Aid, October 1st and 2nd of 1990, I believe. And I went to Lexington, Kentucky, the Kentucky Association of Healthcare Facilities, took the class, and have been teaching ever since. So I've been teaching, whether it's in a facility setting. I taught for the Danville School of Practical Nursing. clinical evening instructor with the LPN class there. That was in the 90s. Job Corps at Big Sandy Community and Technical College, Department of Education. So I've been doing this for quite a while, seeing it get better as far as nursing assistants. So why did they do that? So everybody, whether you're in Maine or California, whether you're in North Dakota or Florida, you are getting basically a certain set of standards you're being taught. And that hopefully will help with the quality of care of residents no matter where you're located, that these things need to be taught. So part of the health science program for you in the evening class to next year, or next year in the spring semester, you'll take the MNA, just a progression. You'll go on to the MNA to become a nursing assistant. So this is a prerequisite. Gives you an idea of how things are set up. Gives you some knowledge, critical knowledge, to be able to work in a healthcare setting. But now, you don't have to stop at being a nursing assistant. You can go on to be a nurse or any other profession. This is a good basis for your continued education and career in healthcare. So let me move on. I digress. Sometimes I do that a lot, so just bear with me. So you have all these facilities. Now, governmental agencies, we hear a lot about it, especially right now, and I'm not going to get into all the politics, but the WHO, the World Health Organization, that is one of the governmental agencies. It's an international agency sponsored by the United Nations. It compiles statistics and information on disease, publishes health information, and investigates and addresses serious health problems throughout the world. And I know we've heard a lot about the WHO recently, but I'm just going to say they kind of oversee and look at everything in order to help with the control and also to help with the health not only of individual countries but for the world. The U.S. Department of Health and Human Services, the National Institute of Health, the Centers for Disease Control and Prevention, the Food and Drug Administration. Now that's important. In fact, hopefully our food and our drugs will be, there's a certain standard that promotes our health and our safety, as all these do. They want to promote health and safety. Occupational Safety and Health Administration, OSHA. When we do the bloodborne pathogen standard, we've done those videos. You see that there. That helps protect us as healthcare workers and provides us information on how to protect ourselves and others. And then, of course, we have our local health departments. We have a state health department. We have that also has local health departments in every county in our state. What about voluntary and nonprofit agencies? Voluntary agencies are nonprofits. American Cancer Society, American Red Cross, American Heart Association. I know Appalachian Hospice is a nonprofit to care for those people who are sick and dying. So they're not there just to make. They're not there to make money. They have to make. All nonprofits have to make a certain amount of money to operate, but they're not there skimming all the money off the top as profit and just running it bare bones. That organization is considered a nonprofit. Money goes back into that organization to make sure that it runs and to provide those services. So. Health insurance plans, how are we going to pay for all this? You know, that's something that everybody's talking about, free health care. Somebody has to pay for something. And through taxpayer dollars, through private insurances, through governmental sponsored and subsidized insurance, helps us with our health care system. We have insurance plans. They can be public or they can be private. They have, a lot of times you'll have a plan that has a deductible. Deductibles are amounts that must be paid by the patient for medical services before the policy begins to pay. So if you have a $1,000 deductible or a $500 deductible, any health care that you have to a certain level, you're going to have to pay that first $500, that first $1,000 or $1,500, whatever your plan specifies, out of pocket before then you become eligible for their plan. Some plans may have a variation of the deductible depending on what type of plan that you may have. A preferred provider organization is another type of health insurance plan, usually provided by large industries or companies for their employees. Medicare. Now, Medicare is a federal government program that provides health care for all individuals over the age of 65 and for any person with a disability who's received Social Security benefits for at least 2 years. Medicaid. Medicaid is a medical assistance program operated by the states. Benefits and individuals covered under this program vary slightly from state to state. The health insurance plan usually pays for the health care of the individual with low income. Workers' compensation. Now that's something that you'll need to know about as well. If you become injured on the job or ill because of your exposure on the job, workers' compensation is a health insurance plan providing treatment for workers injured on the job. Managed care. Managed care is an approach that is developed in response to rising health care costs. They want you to be well. They want you to take care of you, but they want to do it in a manner that benefits cost effectiveness with your health. We've heard a lot about, over the years, a lot about managed care. I'm not going to go into all the details of managed care on this video. Some people like it, some people don't. So let's talk about organizational structure. Now, we started on page 8 in the book, and now we are coming up on page 14. With the structure chart, you'll see that is figure 1.5, and it's a sample of a medical office organizational chart at the bottom and a sample hospital organizational chart. What an organizational chart does, what the structure does, it gives you an idea of how the facility, how the system is set up. In a hospital, you have a board of directors, and then you have a medical staff, you have the hospital president or administrator, or they could call him a CEO, Chief Executive Officer, and then it goes down and it branches out, and you have all the department heads. Now, just a little information that you'll get now, and then of course will be repeated when we get to all these pop-ups. When we get to Medicaid nurse aid, understand that in this organizational structure, everybody is part of the healthcare team. Everybody who works in whether a hospital, a nursing home, clinic, they're part of the healthcare team. There's a healthcare team, and then there's a nursing team. The nursing team is made up of RNs, LPNs, CNAs. That is the nursing team. The healthcare team is everyone else, including RNs, LPNs, and CNAs. The nursing team is part of the healthcare team, but everybody in the healthcare team is not part of the nursing team. So there's a distinction there. But you have everybody from housekeeping, central supply, business office, pharmacy, dietary, nursing, x-ray, therapy, volunteers, and it goes right on down. So you've got the heads of these departments. So you've got the board, the medical staff, the administration, then you have department heads, and then it goes down from there. As a nursing assistant, you report to an LPN or an RN, either a licensed practical nurse or a registered nurse, and they will delegate your tasks to you. You will learn as we go through this program that there is a delegation of tasks. Now, as we delegate those tasks, it has to line up, and we'll talk more about that. But that's the delegation for a nursing assistant. If you have a question about anything, you're going to report that to your supervisor or your charge nurse. Nursing assistants, and I'm kind of going on in the information as M&A because we're here, do not report to other CNAs. CNAs do not report to CNAs. Nurse aides don't report to nurse aides. Now, those are synonymous. A CNA, we have come to recognize that it's a certified nursing assistant. A nurse aide, certified nursing assistant, or a nursing assistant who's not yet received certification but has had enough training to qualify to work in a nursing home, and they can do that under the law up to 4 months until they receive their certification. In the state of Kentucky, we call it an SRNA, a state registered nursing assistant. Matter of fact, when you get your certification, your SRNA, you'll have your information. It'll say SRNA, state registered nursing assistant. Now, there's some things there that some people don't like that term because they think that it might be confused if you put SRNA on a name tag, that it might be confused with a registered nurse, and they don't want that confusion to occur. Because when I was in nursing school, my title was SRN, Student Registered Nurse. And then when I became eligible to apply back in the day, 1989, I had to fill out a paper application to become applicable. So I became an RNA. So I went from SRN to RNA, Student Registered Nurse to Registered Nurse Applicable. So you can see how so SRNA, State Registered Nursing Assistant, kind of resembles some of those older terms. So that's the reason we here generally call them CNAs, nursing assistants. All right, so let's move on. Page 15. I'll back up just for a moment. In this organizational chart, it tells you who you report to. If you've got a problem, what is the chain of command? How do things work within your facility? Where to go to for certain things. That's part of the organizational structure. So you need to know what that is. All right, page 15, trends in healthcare. Cost containment, that's very important. Diagnostic-related groups, combination of services. We saw a lot of that take place in the crisis, healthcare crisis. When you go into the ER, you had one person who could draw blood, who could do EKGs, who could do nursing assistant work. They would have all these things. Instead of having just one person for each EKG, one person for lab, one person for this, one person for that, they multi-skilled workers helped with cost containment because it's easier to pay benefits to one person who has multiple skills in a certain area to work than it is to pay for 5 different people and then also cover the cost of all their benefits related to their job. So it's cost containment. Mass or bulk purchasing helps. Early intervention and preventive services help. And I've said this before in one of my other videos, an ounce of prevention, Benjamin Franklin said, is worth a pound of cure. If I can provide good care to where that resident doesn't develop a pressure ulcer, a bed sore, then one, that patient is going to have a better quality of life, and two, the cost is going to be way down because anytime a patient develops a bed sore, pressure ulcer related to poor nursing care, the cost can be astronomical because it takes so long to heal that and the cost to heal that. So if we prevent it, the patient's better off and the facility's better off. So when we're looking at taking care of residents, it's not only, it's number one about their care and treatment and their comfort and providing a good quality of life. And in the meantime, while doing that, we are preventing excessive cost. Energy conservation. Go out of the room, turn the light off. Now they've got all these automatic things. You walk in, the light pops on. You walk out, so many seconds, the light goes off. FYI, I went into a facility, went to the bathroom. Now this might be a little too much information, but I thought it was funny. So I go into the bathroom, I close the stall door. I'm not there for a long time, and then the lights go off, and I'm like, the power went out. So I'm reaching for my phone, and and I also carry a flashlight. So I got my phone on, I got the light, and as soon as I opened the stall door and moved, the light came back on. I think their timer was set just a little too short, but cost containment. There are some problems with that because if you go in, the timer's set too short, or you're not moving around enough, or it doesn't cover the area, you could be in the dark, and it might not be a power failure. Just a little funny there. Healthcare, home healthcare. If we can take care of you in the home, it's not as costly as if we're in a facility. It's also better for you. Nosocomial or facility-acquired infections is a real thing. The longer you're in a hospital, the more at risk you are for getting a secondary infection. I know it's sad but true. So get you in, get you out, but if we can care for you in your home, number one, you'll be more comfortable. Have you ever tried to sleep in a hospital? Not going to happen. I've been there as a patient. I've been there as a supportive family member. There's not much rest in a hospital. Very, very little rest in a hospital at all, unless they knock you out. Because they're always coming in to check on you. Then you've got people coming in and out, visitors, family. So if we can take care of you in your home, it helps with cost containment, and it also helps improve your quality of life. But now if you're sick, you need to be in the hospital. If I'm sick, real sick, that's where I want to be. I want to be in the hospital. And I want to be there until I'm well, and then I want to go home. All right. So, geriatric care. We've already talked about page 17, the Omnibus Reconciliation Act that led to the development of regulations on long-term care and home health care. I specifically discussed the nursing assistant situation where it required 75 hours of training. I didn't say 75, and I'll cover that here since I've seen it here on 17. I want to cover that just a little bit more. Talked about it developing, signed into law in 1987. The regulations and the program was put together in 1990. It became a reality. It went into process. And the program says you have to have 75 hours. That's clock hours. So 59 of that is classroom instruction. 16 of that is clinical time. That's out taking care of a resident in a clinical setting or having clinical experiences. In that 59 hours, we have a certain course that we teach that you'll learn. and we'll cover the information outlined in the regulation and in the program to make you, hopefully, to give you the information to where you can become a well-rounded nursing assistant. The 16 hours of clinical time, now we're in COVID. There's been some variation to that. I'm not for sure where we're going to next semester when we have that. Nursing homes are concerned about us coming in because of our multiple contacts with other people and then coming into a facility. So we'll have to see what they decide as a state, the regulatory bodies, the facilities, to complete our clinical time. I'm already at 20 minutes. I'm just going to try to cover a couple more sections, and then we may do a part 3. But 75 hours, 59 classroom, 16 clinical. Of course, you'll take this course over a semester. We'll cover a lot of information, and there'll be skills that you will need to learn in that course. But this helps us provide better care for the residents. So I'm going to stop there at almost 21 minutes, and then I will pick up with our next lecture. We finished on page 17. When we come back, we will pick up with telemedicine, and we will finish the chapter. If you have any questions or comments, just send me an email. Look forward again. I want to say again, and I'll probably say it every video until I see you all in person on Monday. And the other thing too is just because we're going to be in person, we're going to keep the virtual thing up. We're going to keep Canvas operating. We're going to keep the YouTube videos going because University of Pikeville yesterday went into a 72-hour lockdown. I think I read 19 cases of COVID. Don't quote me on that. You can read the articles in Mountain Top News and the other places for yourselves. And they had to go back to online classes. We live in a very different time. So guys, stay safe and well. Hope you have a wonderful day. See you.